Hello, my name is Nathaniel Wiest, and I'm a second-year internal medicine resident at the Mayo Clinic in Florida. It is my privilege to present to you today our poster entitled Acute Pulmonary Embolus After COVID-19 mRNA Immunization, a Novel Adverse Effect of a Cutting-Edge Vaccine Technology. My co-author is our Dr. Nair Lugo, who's one of our outstanding first-year residents, and Dr. Eric Edwards, who's one of our tremendous hospitalists. Now, as means of introduction, the COVID-19 pandemic has claimed more than 500,000 lives in the United States and 2.5 million lives worldwide. mRNA vaccination is a cutting-edge technology that has enabled the rapid deployment of effective vaccines against COVID-19. The Moderna and Pfizer-BioNTech mRNA vaccines against SARS-CoV-2 are the first ever FDA-approved mRNA vaccines that give greater than 90% protection against COVID-19 by generating robust adaptive immune responses, as illustrated by the mechanism here in Figure 1. Simultaneously, a significant number of adverse events have been described after COVID-19 immunization, as illustrated here in Figure 2, that demonstrates the local, systemic, and more rare unsolicited or serious events that occurred after mRNA immunization and the studies leading to the approval of these vaccines. Importantly, in none of these studies were venous thromboembolism or pulmonary embolus, or VTE/PE, reported. Now for our case. A 66-year-old man with past medical history significant for hypertension, hyperlipidemia, and renal cell carcinoma, status post-partial nephrectomy 2 years before and in complete remission, presented to our ED with right flank pain and right pleuritic chest pain. He reported that his symptoms began after a second Moderna COVID-19 mRNA immunization 10 days before. He initially experienced systemic symptoms of fevers, chills, and joint pains for about 24 hours that then transitioned to fatigue and progressive right flank and pleuritic chest pain. The events and chronology of this case are described here in Figure 3. Importantly, he denied any personal or family history of VTE or hypercoagulable state. His age-appropriate cancer screening was up to date. He denied any recent immobility or surgery and was in his usual state of health before presenting. In the emergency department, his vital signs were normal. We heard inspiratory crackles at his right lung base, but a full physical exam was otherwise negative. His initial laboratory analysis demonstrated a normal complete blood count with the values illustrated in parentheses, a normal chemistry panel, and a normal urinalysis. However, he had an elevated C-reactive protein and D-dimer. A CT of his abdomen and pelvis demonstrated no acute processes. However, a PE protocol CT angiogram of the chest demonstrated the findings illustrated here in Figure 4, namely segmental and subsegmental pulmonary emboli of the right lower lobe and left lower lobe. Following the diagnosis of PE, a thrombophilia workup was initiated and was mostly unremarkable, including a negative prothrombin mutation, negative factor V Leiden mutation, and normal antithrombin, protein C, and protein S activities. His beta-2 glycoprotein 1 antibodies and antiphospholipid IgG were negative, but its antiphospholipid IgM was weakly positive at 27.1 units. For reference, the threshold for antiphospholipid antibody syndrome requires greater than 40 units. His SARS-CoV-2 spike antibody was strongly positive, but his nucleocapsid antibody was negative, consistent with vaccine-induced immunity without any prior COVID-19 infection. The patient was started on apixaban and discharged home later that day in good condition. Now for discussion. Tens of millions of Americans have received either the Pfizer or Moderna COVID-19 mRNA immunizations with potential for nearly 2 billion doses to be delivered worldwide. VTE/PE was not reported as an adverse event in studies leading to the approval of these vaccines. Here, we present the case of a patient who developed significant bilateral pulmonary emboli after a second mRNA COVID vaccine. Our workup did not reveal any evidence of cancer or thrombophilia other than a weakly positive antiphospholipid IgM. This event certainly could represent an unprovoked and unrelated PE. However, the development of systemic symptoms immediately after the vaccination, followed by overlapping pleuritic chest pain, suggests a possible association. The frequent association of VTE/PE with COVID-19 infection also suggests the possibility of a link between VTE and COVID-19 immunization, which could potentially be mediated by similar immunologic pathways, though this is not known. Given the novelty and immense potential of mRNA vaccines to address human disease, in addition to the nearly 1 billion people that may receive a COVID-19 mRNA vaccination, close attention to adverse events is of great importance. Further studies are needed to assess the correlation between COVID-19 mRNA vaccination and VTE/PE. We encourage all clinicians to have a high index of suspicion for VTE/PE after mRNA immunization and to promptly report any post-vaccination adverse events. Thank you.